TASC at the National Rural Health Resource Center. Today is Wednesday, February 19th, and this is the TASC 90 webinar for February. Our topic today is new models of care and our learning objectives. Hopefully participants will have gained knowledge regarding new emerging models of care influencing rural health providers and have an improved ability to recognize and locate resources related to emerging models of care that will inform their office, partners, or rural providers. We will begin with some TASC updates and then move into Flex program updates from Tori Leach from the Federal Office of Rural Health Policy, as well as Tori will also provide updates from the regulatory side for Carrie Conejo, who is not able to join us today. Sarah Blinkman from Arquita, or Stratus Health, will provide updates from the Rural Quality Improvement Technical Assistance Center, or Arquita. The Flex monitoring team will provide updates from Nicole Barnes, and then we will have Dr. Clint McKinney, John Supplett, and Terry Hill participating in a discussion about new models of care following a brief presentation from Dr. Clint McKinney and John Supplett about new models of care. We will then open it up for questions and discussion, and then we should be ending around 3:30 Central Time. Again, thank you for joining us. Please do take a moment to dial into the phone line for the webinar and mute your webinar speakers when you do that so you are able to participate in the discussion portion of the webinar. A couple TASC updates as we get started. A reminder that the February MBQuip Virtual Knowledge Group webinar focusing on communication and relationship management strategies with critical access hospitals for MBQuip will be tomorrow, February 20th at 2 p.m. Central. The Flex Virtual Knowledge Group webinar will be Monday, March 2nd at 2 p.m., and that will focus on physician and staff engagement. There is an EMS webinar focused on what Flex programs should know about CMS ambulance data collection on March 5th at 2 p.m. Central. A notice or reminder that the National Rural EMS and Care Conference will be held April 22nd and 23rd in Columbus, Ohio. And the Flex workshop will be held in Duluth the first week of April. Registration is open, so if you're interested in attending the Flex workshop that is held in Duluth every spring and fall, please reach out to Angie LaFlamme. That is all I have for TASC updates. Tori, are you on?
Hi everyone, this is Tori Leach with the Federal Office of Rural Health Policy. I'm excited to be with you all today. I know this is the first time I'm speaking to all of you in person, so I'm very excited to be taking on the role of your Flex coordinator. As some of you may know, I was previously on the SOAR team, so I am very familiar with the Flex program, but I'm excited to be diving in as your leader. So on the screen for you is the new map of your Flex project officers. We really appreciate the patience that you all have had with us as we experience some changes within the Flex program on the FORP side. We will continue to serve you to the best of our ability, with Natalia and myself being the co-leads of Flex. All of the states in red and gold will be covered by Natalia, and all of the dark blue and light blue states will be covered by me. So if you have any questions, don't hesitate to reach out to Natalia or I. Just a couple updates for you. For your no-cost extension requests, a lot of you submitted your FFRs at the end of last month. Now, if your unobligated balance was higher than your anticipated no-cost extension, you need to submit a re-budget request in EHB by March 1st. I sent you all an email on January 27th. Please refer back to that email for specific instructions, or feel free to reach out to me with any questions. Now, if your unobligated balance happened to be lower than your no-cost extension requested, we are asking that you please email a budget justification to your project officer. Your non-competing continuation progress reports will be released on March 20th, and they'll be due back to us in EHB on May 15th. I will be hosting an NCC webinar on Wednesday, March 25th at 2 p.m. to go over the specific instructions and to answer any questions that you all have. As Caleb mentioned, my colleague Carrie Cornejo was unable to be with us today. Can we go ahead in the slides, Andy? Thank you. She wanted me to specifically point out the request for information regarding maternal and infant health care in rural communities. So CMS just released this RFI to seek public comment regarding rural maternal health care. Specifically, the CMS Office of Minority Health is seeking information related to opportunities to improve healthcare access, quality, and outcomes for women and infants in rural communities before, during, and after pregnancy. Please submit any comments to rural maternal RFI at cms.hhs.gov before April 12th, 2020. Just a couple of other rules that have come out that Carrie wanted me to make you aware of. The proposed notice of benefit and payment parameters for 2021 was posted on January 31st. The Medicare Advantage contract year 2021 and 2022 policy and technical assistance changes was posted on February 5th. The Medicaid Healthy Adult Opportunity was posted on January 30th. And the request for, sorry, that one was already covered. The request for information for Telehealth Resource Center program is coming from HRSA, from our office, for the Office for the Advancement of Telehealth, and we are requesting information back by March 6th, 2020. And then, of course, the President's budget updates for Health and Human Services was posted just last week for you all. There's also additional resources, such as the National Policy Telehealth Resource Center Guide on Telehealth Billing and the RHC TA Center January webinar archived as well. If you have any questions on any of these policy items, please email ruralpolicy@hrsa.gov. Thank you so much.
Great. Thank you, Tori, and welcome. Sarah, are you there for ARKITA updates?
I am here.
Howdy.
Hi. So just a few updates from the ARKITA side of things. We do have a virtual knowledge group tomorrow for MBQIP. The focus is on communication and relationship management strategies with critical access hospitals for MBQIP. And this is based on feedback that we received through our annual assessment the end of last summer, as well as some feedback that we got on a recent BKG where we asked for thoughts on topics to cover. Folks were interested in how you all are managing your communication with your hospital, site visits, orientation for new staff, things of that nature. So we did send out an update about the call just yesterday morning, I believe, and there are some questions in that email that we would like to encourage you all to reflect on and come prepared for discussion. We do have some folks lined up to share examples, but this is, as always, those calls are meant to be for you all for some networking and peer sharing, and so we hope that you'll come prepared to share as well. We want to make sure that everyone is up to date and knows about all of the different resources that exist to support the change in the Emergency Department Transfer Communication Measure. There are now videos available on the EDTC resource page, which you can get to by searching on the center's website for EDTC resources. You'll be able to find the updated specifications manual, a training walking through the specifications manual, the updated Stratus Health Excel-based tool for abstraction, and a video related to that, as well as a non-macro version of that tool based on some requests that we received from hospitals. So please make sure that you're checking out those resources. We will continue to promote them through MBQIP Monthly, which is our primary way of being able to reach out to the hospitals, but of course that relies on you all to spread the word as well. We just want to make sure that we don't want any hospitals to find it to be a surprise at the end of this first quarter of 2020 that they need to be using a new abstraction tool. So we want to make sure that you're getting the word out, we're getting the word out, and that you have your processes in place for collecting the data clearly articulated to your facilities. A reminder, as always, that we have the Abstracting for Accuracy project that is available for hospitals. So as we move from a focus on quality reporting to quality improvement, it's really important that we ensure that that data is accurate so that we can be using the data to drive our quality improvement efforts. Robin is available to do abstraction for accuracy with facilities that are interested, and that information is all available on the TASC website as well, and it's always promoted in MBQuip Monthly. We wanted to call your attention to some of the CAUSE-CAN profiles that have been posted in MBQuip Monthly as of late. So in November, December, and February, we had antibiotic stewardship critical access hospital profiles, which were pulled from the facilities that participated in our focus groups last spring. And so we will be compiling those profiles over time as we collect more of them and developing them into another resource to supplement the focus group findings resource that was published in September. And then we also wanted to call your attention to, in the January MBQuip Monthly, we launched our National Virtual QI Mentors program. So we announced who the mentors were and what we're planning to do over the course of the next couple of years with them. We're really excited about that project. And our first recorded conversation with them will be coming out. We intend to promote that with our April MBQuip Monthly. So not the one that you'll get from us in about 2 weeks, but the one that you'll get in about a month and a half. And so we hope that you'll all be watching out for that and look for opportunities to promote that with your facilities as well. And that's all I had for today.
Great. Thank you very much, Sarah. We have one request that you please send the invite to the MBQuip Virtual Knowledge Group webinar again. Nicole, are you on for the Flex monitoring team? Star 2 will unmute your line.
Hi, everyone. I just have 3 very brief updates from the Flex monitoring team. First, we released our HCAHPS report last month, so I hope everyone had a chance to review those. And please feel free to email us if you have any questions. The annual hospital compare report should be out early this spring, either in March or April. And then finally, we will be launching our totally redesigned website early this summer, hopefully in June. So watch out for that. That's all we have. Thank you.
Great. Thank you very much. Are there any questions for or from any of the updates that we received? Again, star 2 will unmute your line. All right, hearing none, I will let Andy put up our pre-presentation polling questions as I introduce our speakers. So John Supplett, who many of you know, is a Senior Director of Rural Health Services at the American Hospital Association. Since 1993, he's worked with on behalf of the American Hospital Association's 2,000 rural hospital members, including the 975 critical access hospitals, to help develop and advance their unique healthcare interests, issues, and perspectives. He is a contributing member of many of our updates generally, and a great friend to the TASC team and the Flex team. So please join me in welcoming and appreciating John for his participation. Dr. Clint McKinney has worked in healthcare for nearly 40 years, including 14 years as a rural family physician, practicing full scope of family medicine. Most recently has worked for 15 years as an emergency department physician in rural Minnesota. He's been a member of RUPRI Health Panel since 1998 and has served on national committees for the Institute of Medicine, the Department of Health and Human Services, the American Academy of Family Physicians, and the American Medical Association. In his capacity as rural health advocate, Dr. McKinney's publications include many numerous things on value, health system design, physician and administration relationships. And we are very glad to have him and John here to discuss some of the new and emerging models of care for critical access hospitals in rural across the country. So please take a moment to complete the polling questions, and we will get our presentations lined up. All right, Dr. McKinney, are you there? *2 will unmute your line.
I am, Caleb. Thank you very much.
Howdy, thanks for joining us.
Sure. So I'll go ahead and get started, and thank you very much, Caleb, for that presentation. John and I are pleased to be here and talk with you this afternoon and give you just a little bit of primer about value-based payment and value-based models. That's our intent, and we hope we'll have plenty of time at the end of our comments to field some questions from all of you out in the field. So let me just make sure I have control here, and I do. So I want to start off with kind of where we all should be, and that's with the triple aim. And you all, hopefully, are familiar with the triple aim. This was actually coined by Don Berwick, and when he was the president and CEO of the Institute for Healthcare Improvement back around 2008. And then he co-opted it to become the three-part aim for CMS when he was with CMS. And I really like it. I like it because it's simple. And I think if you were sitting down and having a beer or a cup of coffee with family, friends, or neighbors, and you ask them what they expected of the healthcare system, they would say this: I expect to be made better. You know, I expect to be treated with respect and compassion. I expect the same for my family and my neighbors and my friends. And I don't want my hard-earned money to go to waste in the system. So that's the triple aim: better patient care, improved community health, and smarter spending. That translates into this concept we've been talking about called value. And back just a little bit before Don Berwick wrote his article, I was asked to give a talk in the UP of Michigan about why we as providers were being forced into healthcare reform. And I kind of came up with this idea that we weren't delivering the value we all know we're capable of. And I'm not a mathematician, but you know, I can add and divide. And I said that healthcare value, which we're not delivering what we know we're capable of, is quality, clinical quality, plus the patient experience divided by cost. So that's where this kind of value kind of concept comes from. But as we all know, we got a problem here. And the problem is, in general, we are not paid in general for quality and patient experience and reasonable use of costs. Instead, we're paid for fee-for-service. We get paid for doing things to people, whether it hurts, helps, does nothing for them. So what I want to talk about today is kind of alternatives to fee-for-service. And I call this the value-based payment continuum. And you can see on the left side is fee-for-service, kind of where we are now, and I'll talk about that in a moment, going all the way to the right, which is total cost of care. And we have these iterations in the middle. that we're trying to kind of experiment with this movement from fee-for-service towards total cost of care. But if you kind of keep this graphic in mind as we're maturing in our healthcare system, and in particular our healthcare payment system, it may help kind of think about the journey that we're on. So I want to start with talking just briefly about fee-for-service, because that's where we all are, and then kind of describe two of the most prevalent and most promising models that are going on right now, both shared savings and global budget. So let me kind of talk about that. So first, our roots, which are in fee-for-service. Now, as I said, fee-for-service is payment for individual units of service. Think of all the CPT codes. There's roughly 8,000 or 10,000 of them. That's a service. And the RVS Update Committee, called RUC for short, assigns values to each one of those services, and that's translated to dollars, and that's how we get paid. At least through Medicare, and the commercial insurers tend to follow that lead. So we've got 8,000 or 10,000 different services that we're getting paid for on a piecemeal basis. And by the way, importantly, cost-based reimbursement in critical access hospitals and prospective payment systems in the larger hospitals are fee-for-service systems. So this is kind of like producing widgets. Now, it's not all bad. It's not all bad. It rewards industriousness. It rewards hard work. It rewards organizations that are efficient. But in this, volume is king, not necessarily health care. So how organizations remain successful is putting people in the hospital, seeing patients in the clinic. That doesn't quite fit with that value equation I was talking about, and probably doesn't quite fit with what you want for your mother. You know, do you want your mother to be cared for by organizations and professionals who are paid to do things to her, whether they help, hurt, or do nothing for her? So I'd argue that we probably need to move beyond our pure fee-for-service environment. So what do? Well, the most dominant player right now in the value-based care and value-based payment universe are the shared savings plans, or more familiarly called the accountable care organizations, or ACOs. Now, what these organizations are, they're separate organizations from a hospital or a physician group or an insurer. They are groups of providers, generally doctors and or hospitals, that receive financial rewards to maintain or improve care quality for a group of patients while reducing the cost of care for those patients. Now, lest you think that this is not all that popular, take a look at the statistics that are on the screen here. This is as of July 1st, 2019. We've got nearly 1,000 public and commercial ACOs in the country that are covering over 44 million lives. Now, you guys can maybe do the math faster than I can, but I think that's about 15% of the U.S. population. We're getting close to 20. And you can see the breakdown there. So these organizations called accountable care organizations or shared savings plans are spreading. You can see it here in a map that shows the penetration of ACOs by state. Now this is 2017 data. It's changed a little bit since then, but not that much. And you can see here, those of us in the upper Midwest, we haven't met an ACO we don't like. Minnesota, Iowa, North Dakota are quite high in the number of lives in our states that are covered by ACOs or cared for by ACOs, in the 20% range, same way in the Northeast. A little bit less in the Deep South. Now the way these organizations work is this. Let's just make an assumption that CMS calculates the cost of care for our average Medicare patient to be $10,000. They predict that going from 2019 into 2020, that this particular Medicare patient is going to spend $10,000 of taxpayers' money during that time frame. Along comes the ACO, and the ACO says, I'm going to take care of this patient with higher quality and lower cost. So how does that work for me? Well, at the end of 2020, if Medicare recalculates how much this patient actually costs the government from all situations, whether they are in Minnesota, whether they're in the local hospital, whether they're Mayo Clinic, or they're snowbirds down in Fort Myers, all those costs are compiled. And if at the end of that year, Medicare spent $500 less in this particular example than the $10,000 that they predicted they would spend, that particular ACO realizes a $500 savings. But wait a minute. Remember, we have to do good quality at the same time. So if their quality is darn near perfect, they will actually get a check back for this patient for $250. That could be adjusted down a bit if their quality is less than optimal. So the idea here is in this fictional situation, which probably isn't too far off from the average, if an organization, if an accountable care organization saves $500 for the Medicare system, they will receive back up to $250 for that savings. That's how an ACO works. Now let me contrast that to something a little bit different, and that's global budget. And you may be hearing a lot about global budgets, but they're pretty limited. I'm doing a fair amount of work with the Pennsylvania Rural Health Model, which is a rural hospital global budget. There's also a global budget system for hospitals that's been going on in Maryland for about the past decade, and they just this year added physician practices into that. But let me back up and tell you what a global budget is. So a global budget is a single unchanging payment per fixed period of time. It's easiest to think about it, and there's lots of complications, more than I'm going to describe here, but it's easiest to think about it as getting kind of a pot of money, say that $10,000 for the Medicare patient at the beginning of the year, and then you are asked to take care of that patient for the rest of the year for that $10,000. If you spend less than that $10,000, you get to keep the difference. If you spend more, well, that's a problem. You have to come up with the difference. This is kind of like a health club. You know, it's January 1st. Everybody's made their New Year's resolutions. Everybody's going to exercise and lose weight. You pay that $300 to that health club, and then what does the CFO of the health club want you to do? He or she wants you to stay home and not come to his facility, use their towels, use their hot water, break their equipment. What they really want you to do is remain healthy at home. Now, I'm being facetious, of course. But the point is, if you're given the pot of money from a financial standpoint, you want to do everything in your power to keep people healthy, rewarding health maintenance, and still being efficient. We used to have the joke that the CFOs would really like a flu epidemic because their hospitals are filled. Not anymore under global budgets. All of a sudden, the value of that community flu vaccination program becomes real dollars in savings to the hospital. Very important. Now, this is probably the most important financial graphic for those hospitals who are considering a global budget. If we have thoughtful, forward-thinking, and honest hospital leaders who are trying to make a determination about whether global budgets are right for them or not, they need to look at their financial trend lines. And this isn't their revenue lines. And they need to think about how much money are we making now, how much money do we think we'll be making in the future year over year over year. We can cut cost only so much. And what do we think that Medicare payments or commercial payments are going to do over the future? Most of us think they're not going to be going up dramatically. And most of us in rural are pretty efficient already. So if we're seeing a downward trend in our revenue, this is where a global budget can really make sense. So you see my fictional hospital here who has a revenue of $10 million per year from Medicare in 2016, but they see a decline of nearly $2 million by 2019, and they're being honest. They don't have a whole lot of patients. Their population is shrinking. They don't think their revenue is going to go up. But what a global budget does is it locks in that revenue at the time you set it. So you can see going forward, I now have this revenue that I didn't have if my trend model would have continued. So why would you agree to this global budget idea if it were offered to you? Well, I had one hospital CEO say to me in Pennsylvania that it gives us financial breathing room. It gives us time to kind of figure out our systems and let the nation figure out its payment systems as well too. It's probably very appropriate to consider if you are a hospital where you're seeing that downward trending patient revenue like I mentioned. If you're in a service area where there's low patient volumes or you're a financially distressed hospital as well, it's probably not appropriate for hospitals with upward revenue trends. Now, I've hardly met a hospital leader that doesn't think that he or she can steal market share from a competitor and do better. Well, if you really think you can do that, I suppose that fee-for-service like we're getting now continues to make sense. But it does require some candid thinking and introspection, doing good pro formas for your organization regarding price trends and volume predictions. If you're being honest and you say, I think I can continue to make more money next year, more revenue next year than I did this year, then maybe global budget isn't right for you. But nonetheless, many rural hospitals are not in that position right now to be able to say we are going to continue to increase our revenue over time. Now you might also ask, and it would be appropriate to, what are the risks of this global budget? Well, we first have to step back and say that 160 hospitals have closed over since 2005 or 6. There's a multitude of reasons why those hospitals may have closed, but almost in all, it comes down to eventually a financial issue. So if I remember right from the statistics from University of North Carolina, 2019 had the highest number of hospital closures in that time period that I just quoted. So this trend doesn't seem to be slowing down dramatically. So it's important for us to all realize that many rural hospitals are already at financial risk, But still, it's important to think about the risks of a global budget. First, there's a risk that your volumes or your costs go up, and the global budget doesn't account for your increased volumes that you did capture from a competitor hospital. If a global budget locks in historic revenue, but remember, even though that locks in that historic revenue, reducing costs is still challenging. Future budget adjustments we just don't know about. We don't know if things are going to be adjusted in the future. And maybe importantly, we don't know if the largesse allowed by a global budget will be enough for hospital survival. And lastly, there's a risk that I think we wish wouldn't be the case, but still there's a lot of business office work that still needs to be done around a global budget. We still have to code and submit claims because, for example, there's risk adjustments. We have to collect co-pays. We have to do quality assessments. So the idea that we can really streamline our financial organization because of a global budget probably isn't the case, at least in the short term, though we'd like to get to that. But I'd like to also kind of talk about the potential of global budgets kind of beyond finances. I suppose it's important to emphasize that when we talk about accountable care organizations and fee-for-service and global budgets and all the other permutations of our payment system, that's what we're talking about, payment system. We're really not talking about the care of patients. So I like to think of global budgets in different ways than simply finances. First of all, this is a really exciting managerial challenge. Wouldn't it be interesting for hospital leaders that were truly concerned about the health of their communities to be able to now have the financial impetus to actually develop resources and expend those resources to keep the community healthy and have that pay off in reduced ED visits or reduced readmissions or reduced hospitalizations. Wouldn't that be interesting? And wouldn't it be an interesting challenge for a healthcare leader who was trained for many years to emphasize revenue growth due to volume growth, and now say, how can I keep my community healthy? It's an opportunity to be innovative, and most importantly, I think it allows us to focus on mission. So if we were to look at the missions of most rural hospitals, they probably say something like this: we provide high quality care for our community because they are our neighbors. Well, actually, I don't think there's anything really wrong with that, except for one thing. If keeping people really healthy, if that's one of our goals, it's kind of in direct contradiction with our need to put people in the hospital and make money. So wouldn't it be neat if we could start to marry what we kind of know in our hearts is the right thing to do for our patients and our community, and that is to keep them well, keep them out of the ED, and keep them out of the hospital, and make that congruent with our payment system as well. It's balancing that duty of healthy community and the duty of financial viability for our organization. Here are some other sources around healthcare value. You'll see the National Rural Health Resource Center there, and John's American Hospital Association there as well. So you'll have those resources if you need them. There's a lot of resources out to help you kind of move in this journey from volume to value-based care. And of course, we at the Rural Health Value Team are always willing to help as well. And with that, I'll turn things over back to Caleb and to John. Thank you all very much.
Great. Thank you very much, Clint. Before you remute your line, we do have one question from the chat box from Catherine Miller. With global budget payment, is there a danger of a hospital cutting corners on treatment if the patient has compounded medical needs, or to deny treatment? Not to deny treatment, but to not choose the more expensive and effective treatment. Is there a quality aspect of this to maintain?
Catherine, thank you very much for that question. Yeah, that's a very good question, and I didn't have time to go into that particular issue. But the very same quality metrics by which we're starting to assess hospitals and physicians are being applied in global budgets as well too. The concern about stinting, that's the word we use, stinting on care, is real. And I would probably say that the risk of hurting people through inappropriate or overuse may be just as great. So we don't talk about that as well. I also want to talk about your very last line, though, which is maybe not choose a more expensive and effective treatment. And if we are choosing a treatment that is equally effective or more effective, we should be choosing the lower cost one. We should already be doing that. So the effectiveness is key, and when we start talking about cost effectiveness, that's when we're blending both the cost we're paying for that service and effectiveness. And that's a dicey, difficult economic analysis, but one we really should be doing more of. So the quick answer to your question is yes, you do need to monitor, but I am going to suggest that we as professionals will not try to hurt our patients in the process of saving money.
Great, thank you very much, Clint. And I encourage others to keep typing questions into the chat box there on your left as well. We should have plenty of time for a good discussion following John's presentation. We have a few questions and comments already identified for after John's slides here. So, John, are you there? *2 will unmute your line.
I am here.
All right, welcome.
Thanks for having me. Well, Catherine, I'm going to start with your question too, because there's perverse incentives in both fee-for-service and global budget, as Clint has pointed out, and I think it's up to the system to manage those incentives so that we don't lean too far one way or the other. And I think we've done that effectively through fee-for-service and would do that equally effectively through global budgets or ACOs. But you know, those incentives always exist regardless of the payment system. So Caleb has invited me to talk to you about new models of payment and delivery, and I agreed to do that reluctantly because it is a very meaty subject matter. Clint has done a fabulous job of talking about two of the most high-profile types of new payment models, the ACO and the global budget. And those are the ones that many of us who work in healthcare have focused a lot of our efforts and energy. But those aren't the only models of payment and delivery that are out there. And I'll spend a little bit of time touching on some of the other options as well. The interesting thing about the ACO model, as Clint pointed out, there's about 1,000 accountable care organizations out there covering 44 million lives. But of those 1,000 and those millions of lives, less than 100 of those ACOs would be rural-based, and the number of lives would be more along the lines of 2 million from those ACOs. And the reason for that is it takes size to spread risk. And we don't see, my screen just went off. We don't see.
I can advance for you, John. Just let me know when.
Interestingly enough, yeah. We don't see the ability to spread risk in small rural communities the way we might in larger ones too. Okay, so I'm back on. So let's jump into this. Before I go into new payment models, I want to just touch base on the old models of payment and delivery so that we know the frame of reference from which we speak. And on this chart, you can see this very busy chart. This is how we are paid as acute care hospital inpatients prospective payment system. And it is a fee-for-service model, as Clint has said. And if the slide makes you dizzy, that's with intent. The acute care hospital inpatient prospective payment system is not only a mouthful to say, it is complicated to follow. And this particular flow only speaks to operating-based payment rates. It doesn't even consider how hospitals are reimbursed for capital. Because this old model of inpatient PPS didn't work for everyone, there were payment adjustments made to accommodate vulnerable rural hospitals. And these too are complicated. And again, if this slide makes you dizzy, that's intentional. You can see two of these adjustments were critical access hospitals, the ones with which you're probably most familiar, Soul Community as well. But as you look at the detail on those slides, what you see are the limitations that are placed upon eligibility and payment depending upon any of a number of circumstances that truly are beyond the community's control. And here are two more examples of the way in which the old model didn't work and adjustments were made for Medicare dependent and rural referral centers. Now, mind you, each of these four adjustments are considered cost-based reimbursement in some form or another. That is, it's taking the inpatient prospective payment model and adjusting it to guarantee a certain level of payment to these categories of hospitals, provided they're eligible and they meet the criteria to participate. Again, very complicated, very difficult to manage even if you're in it. And again, we wouldn't be talking about it if they were successful for everyone. So what we already know is that despite the best efforts of Congress and federal agencies, these payment models are inadequate for many rural hospitals. The sky is falling. Rural hospitals continue to close, as you can see from the graph, the bar chart there. Practice patterns have shifted dramatically from 2010 to 2017, with the number of Medicare outpatient visits per beneficiary increasing by 22%. And by contrast, over that same period, the number of Medicare inpatient discharges have declined by 14%. If you haven't kept up your practice patterns to adjust for that change in shift, then you find yourself to be very capital intense, and that means probably over leveraged. Drug prices have also skyrocketed, which is measured by the individual national drug codes, as you can see on the slide on the right. Prices for drugs and biologicals under the Part D rose 83% cumulatively between 2006 and 2017. And as you can see, the only Part D covered drugs that were price reduced were generics. And these are taken from the MedPAC's June 2019 report, so that's current information. Now, AHA has attempted to intervene in many ways in respect to new payment and delivery models. We had an AHA board task force on the future of rural health that helped identify essential services and payment and delivery options other than traditional fee-for-service. We have a rural report that identifies the challenges that are confronting rural providers and an advocacy agenda that tries to address those challenges through legislation. Here you have 6 different categories on that advocacy agenda, but the first one is supporting new payment and delivery models. We also have a task force on the future of rural health care, which is a board-level task force that's going to report back to the board what they see as the future and how we can make accommodations to ensure care and a medical presence for rural communities. And now we've had some victories. We've extended and reauthorized some of these old models. We've created patches to prop up these old models. And we've raised the visibility of rural hospitals and the challenges we face. But the reality is we still haven't met the need for new delivery and payment models. The administration has identified this as a priority as well. CMS has, in 2016, established a Rural Health Council that addressed 3 strategic aspects of care delivery: improving access to care for Americans living in rural settings, supporting the unique economics of providing health care in rural America, and ensuring that the healthcare innovation agenda fits rural healthcare markets. And the strategy supports CMS's overall effort to reduce provider burden and align other CMS priorities, such as improving quality of care and tackling the opioid epidemic. Health and Human Services Secretary Alex Azar has created a Rural Health Task Force at HHS to identify the needs of rural communities, how to meet those needs, and what HHS policy changes can address those needs, not only how to deliver care in rural areas in a sustainable manner, but also how rural health care may change in the future. And in September, we, among others, sent a comprehensive response to the HRSA's request for information on access to health care services. And Congress has also identified the importance of addressing the needs of rural health care providers in their House Ways and Means Committee on Rural and Underserved Communities Health Task Force. That task force met last July. They convened members and experts to discuss the challenges of delivering health care in rural and underserved areas and explored holistic bipartisan policy options that can improve outcomes of care in these communities. Yet, we still have not found the solution for our providers. CMS established its Innovation Center, which was mandated by the ACA in 2010. It has produced dozens of new demonstration models, and I'll touch upon a few of those as well as part of the experience and the need to advance and be proactive about delivery and payment in rural communities. When we look at some of the innovations that have come from CMMI, we see the Accountable Care Organization, which Clint spent some time on already. What's interesting as part of this demonstration project was the Advanced Payment ACO model, which provided prepaid shared savings building on the experiences of advanced payment. This ACO investment model was developed in a response to stakeholders' concerns about the availability and access to capital needed to invest in the infrastructure necessary to implement population care management that Clint described earlier. 45 hospitals participated in the AIM ACO model, and it was successful. It did reduce spending and utilization compared to Medicare fee-for-service beneficiaries. The reality is that model sunset, and so it's no longer available for rural providers to participate. It does present, though, an interesting option should we move forward and it be reauthorized. Another example of innovation coming from CMS was the Bundled Payments of Care Initiative, or Bpci. And in this case, the provider entity that assumes financial liability for the episode of spending. So episode initiators include acute care hospitals, skilled nursing, physician groups, home health, inpatient rehab, and long-term care, any of whom can trigger an episode of care. And across the episode payment models, the common lessons that emerge from the themes include target price setting, which became the most important parameter of success with episodic payment. If the target wasn't set properly, and that is a very exact science, then the model did not work. Other common themes are beneficiary attribution. To whom is the Medicare beneficiary assigned with respect to the episode indicator and the awardee, and then overlap of beneficiaries. How do you segment the beneficiary and then the money that follows that episode of care based upon overlap between the beneficiary and primary care providers? And while the results from this innovation were promising, performance payments are included in episodes. The reductions in payments was not resulted in net savings thus far. So the jury's still out on bundled payments. The next innovation is called the Enhanced Flex in Payment and Care Delivery, which is really another way of identifying global budgets and other cost-based reimbursement. One of those was the Rural Community Hospital Demonstration Program, which was testing the feasibility of cost-based reimbursement for small rural hospitals that were too large to be critical access. And in the first year, these hospitals are paid based on reasonable costs, and in subsequent year, they're paid on the lesser reasonable cost or target amount. And the observation here and the outcome was that they were, if you were a winner, you were a big winner, and if you were a loser, you dropped out of the program. And all that had to do with the difference between the hospital's base year payment and target payments moving forward, much of which would have been driven by capital expenditures in that first year. So those that did win won to the tune of something like 41% increased revenue during their participation in the program. And those who lost basically dropped out of the program and converted back to critical access hospital if they met the federal eligibility requirements, or they converted into sole community or Medicare dependent. And then another example of this type of care is the Frontier Community Health Innovation Project, which was to test models of integration and coordinated healthcare in sparsely populated rural communities with the goal of improving health outcomes and reducing Medicare expenditures. CMS expects critical access hospitals to increase access to services. So this was 10 participating critical access hospitals that were located in Montana, Nevada, and North Dakota. And the demonstration lasted for 3 years, and there were 3 interventions that these critical access hospitals could direct their attention to: ambulance services, skilled nursing or nursing facility long-term care or swing beds, and then telehealth. And the findings were that the ambulance and skilled nursing and nursing facility interventions were implemented relatively easy with little burden on the participating critical access hospitals, and they were able to use existing resources that were idle. For the telehealth, utilization grew, but the challenges with telehealth related to technology and operational issues were the same for these demonstration hospitals as they are for any hospitals. And they are issues like credentialing, IT, and bandwidth, broadband. And then the last of these innovation demonstrations that I'll touch upon from CMS was the primary care transformation, or the Frontier Extended Stay Clinic, which allowed remote clinics to treat patients for extended periods, including overnight stays that entailed routine physician visits. But to be eligible, you had to be a community that was at least 75 miles from the nearest acute care hospital or critical access hospital. And this project lasted for 3 years. There were only 5 participants, 4 of which were in Alaska and 1 on an island in Washington State. And there are 5 key lessons learned from the Fesc program. The first is the demand for extended stay services among Medicare beneficiaries is low. The second is extended stay services did improve the beneficiary's experience. The third was extended stay services promote appropriate monitoring and observation services. But the fourth is that the frontier communities would not likely be able to sustain these under fee-for-service Medicare. So in order for the Fesc demonstration to continue, it would require additional funding from Medicare. Now there's other innovations that are out there that merged from the field as communities and providers try to, again, maintain a medical presence in their communities. But sometimes it meant downsizing the inpatient acute care facility into some other model of delivery, such as a freestanding emergency department or urgent care center. And there are successful examples of that transition that we are familiar with. But again, it means the community has to make a decision that it can no longer support inpatient acute care and recognize that that there's other ways to maintain a medical presence to support their vulnerable rural communities. So I will stop there and take any questions and turn it back over to Caleb.
Great, thank you very much, John. We have one question that came in as you were going through your slides, and that was the question of whether or not there's a common denominator on why the rural hospitals are closing.
There are actually common denominators, and it's been presented to us in studies that were published by the University of North Carolina Sheff Center for Rural Health Services. And the common denominator is bypass, that the volume for these hospitals would no longer support the inpatient capacity. That is, that the overhead of running an inpatient hospital was too great to be met by the number of patients they were able to serve on an inpatient capacity, which is that transition in practice patterns from inpatient to outpatient that I referred to earlier. As we are better equipped to provide care on an outpatient basis, it also means that the inpatient infrastructure continues to linger and has to be supported financially, but there aren't the resources there to do it.
Great, thank you very much. So we do have a few questions coming into the chat box, so I appreciate that and keep them coming. We'll read them for everyone's benefit. And Clint, John, and Terry, I encourage you to unmute your line and begin participating in this discussion as well.
Okay.
We hear that CMS is developing a template rural global budget model that was to be released late last year. Can anyone confirm that such a template is being developed, and if so, when it's expected to be released?
Peggy, yes, we can confirm that it is still being developed. It is under development, and we are anxiously awaiting an announcement from CMS on that as well. And we would be expecting some time between now and May 22nd when the federal budget will have to be reauthorized at that time, that there will be some sort of an announcement relative to the next iteration of the CMS strategy.
Great. Thank you, John. And here's our next question from the chat box. Despite a large and growing body of research supporting the association of upstream social factors and downstream health outcomes, the Affordable Care Act's performance incentive payment mechanisms neglect to directly risk adjust or otherwise compensate for treating social determinants of health. Do you anticipate for CMS to make these changes with its growing research, sorry?
And Stephen, I will say, I will give CMS the benefit of the doubt here, and my colleagues can disagree, that yes, they do understand the impact that the social determinants of health have on the care of the population, and there is a desire and a willingness to pay for that. But what's missing are two things. The model under which they could implement payment for social determinants, and the second thing is the money. Now, you mentioned CMS and Medicare, but commercial health plans are also seeing the power of social determinants. And when you put it in the context that Clint created for us at the beginning of this discussion, that is keeping patients at home and treating them in the lowest level of care reasonable, there is incentives that are being developed by commercial plans to reimburse for social determinants, such as housing, transportation, and food.
Yeah, John, let me jump in here. This is Terry. You know, Kaiser has done a pretty incredible job on that. It's, again, one of our oldest health maintenance organizations. But increasingly, we are seeing healthcare systems, hospitals reach out, provide housing, for example. And one of my favorite stories, and some of you may have heard this already, was the state of California, who looked at their costliest Medicaid patients and got some sort of a waiver so that they could actually they found out that about half of their costliest patients, the very costliest ones, were homeless, and they were able to provide housing for these homeless folks. These patients, in some cases, had 62 I just remember one patient in particular had 62 separate ER admissions and then discharged to the street. So once they started putting, they gave them free housing, and in a couple of cases even bought puppies for them so they'd have some sort of, I mean, isolation and loneliness is a horrible thing as well, and it directly affects healthcare. And they saved a ton of money that way because that poor person had some place to go. And I think that there's great advantages here, but I will agree with John. The commercial insurers seem to be ahead of the pack here.
You know, I might add, this is Clint, I might add that we see these innovations coming out of people who hold the purse strings. So in as much as I want our healthcare system and the $3.3 trillion that it involves to address social determinants of health, if we bring that back down to a hospital who even though the payment might not be much for a Medicaid patient, but they still get paid. And so if we're asking that hospital to absorb that loss of revenue, how do we make our providers whole when we start keeping people out of the hospital and out of the emergency department? Now, one of the ways that we can do that, as Stephen pointed out, is to start recognizing social determinants of health issues in payment. The other challenge, in addition to what John mentioned, is how to risk adjust this. So maybe that's, John, what you're suggesting about how do we pay for this. So one of the initial steps that thought leaders have tried to do is consider the dual eligibles. So if we have a Medicare patient who's also on Medicaid, that automatically or statistically increases their cost of care, often because of issues related to social determinants of health. So that's a very basic, fundamental, but still a start in a way that we might be able to risk adjust our Medicare patients for social determinants of health.
Great, thank you guys. I think
we got to get to Kyle's question here with respect to if a CAH has a low volume, should we expect it to close soon? And
yeah, and that's her first question of do they help those hospitals with low volume?
Yeah, and the answer to those questions are if the providers in those communities and the communities and the leaders in those communities don't adjust to the market around them, then yes, they can expect to close. Because if practice patterns have changed and they're not keeping pace with that change, if they are not in tune with the needs of the community, and if they're not working very closely with the area employers, if they haven't changed the way in which they are delivering care, then they can expect to close. And that's part of the message here that we are bringing to our providers, is that the market has changed and we need to change with it. And part of that means is that we have to look at our services, our patients. We have to be very dedicated to our community health needs assessments, not just as an IRS document, but as a true strategic plan of the community's needs, and to adjust accordingly. And that means trying new things. And it takes vision to do that. And we really have to depend upon the leaders in these communities to bring that vision into play.
Yeah, I think
one of the things that you go ahead.
Go ahead, Phil. I just wanted to add on that I think to just expand that discussion a little bit beyond just the low volume on the inpatient or even outpatient side of the hospitals, to one of the questions that we discussed prior to the webinar was whether or not rural hospitals should continue to focus exclusively on sick care or start to dabble or expand into population and community health, which I think is what we're talking about now.
Yeah, let me make a comment. First of all, I agree with everything that John has said, but I'm on the board of the National Rural Accountable Care Organization, so we've got access to a lot of information, which is comprehensive. I mean, that's one of the benefits of being in an ACO is that you get comprehensive 360 data on all the dollars spent on Medicare. Usually you don't have access to that because if your Medicare recipient in a rural community goes to an urban area, they may not know who they went to or what the amount of money spent, et cetera. So when you take a look at where the money is spent and you factor in the folks assigned to you in your accountable care organization, one of the really shocking pieces of information is that our rural hospitals are losing over 50%. In fact, it's significantly over 50% of the revenue that is being spent for services that are available locally. And we've known that for quite some time. Our center has been doing community health assessments for over 20 years right now. And what we recognize is that there's significant outmigration for care here. And it's really hard to get this point across. There's this assumption that the folks that are leaving, sometimes they go because they don't trust the local hospital, but I think there's also some sort of conclusion that oh, most of that is care that we don't have available here. But the data it really contradicts that. It's just simply, and I think John suggested a remedy here, and that is we need to work closer with our community. Our community does not recognize, and I'm speaking the we here just in terms of hospitals and clinics, because our community truly doesn't understand the services available. And frequently, all too often, they leave because they don't know cardiac rehab is available locally. I remember Pascal telling me in the case of one patient that the specialty hospitals don't know that cardiac rehab is available locally in many cases as well. So I think that really speaks not to big billboards and slick advertisements, but to greater engagement in the community itself, and to get the folks more involved and more understanding what's available.
Absolutely, thank you. And we had a few comments come in, more comments than just questions, as far as getting your state legislature on board, so to speak, with the possibility of expanding the Medicare, Medicaid, and then Jack here from Montana mentioned that again, low volume alone does not guarantee closure, but it is one of the things to consider, that the small need to continue to change. Bill Jolly from the Tennessee Hospital Association, were you able to join us today? *2 will unmute your line if you're there. It doesn't sound like he was able to, but I'd asked him to join and participate in the discussion portion of this webinar, if he could, to talk about some of the efforts underway in his state and from the Hospital Association to help inform.
Hey, Caleb, this is Bill Jolly. Can you hear me now?
Hey, there he is. How are you, Bill? Thank you.
Good. Sorry about that.
No worries. Thank you for joining us. So if you're able to talk a little bit about your experience there in Tennessee and what you guys are kind of up to and helping inform some of the legislature and do some of that. I don't know that that's going to cure everyone's examples, but I think it's another good example of what some states are doing and up to.
Exactly. So when I thought Clint just did a fabulous job sort of explaining, the aspects of global budgeting, and those are the same conversations that we have had here. And honestly, we were trying to position ourselves in anticipation of an expansion of what's going on in Pennsylvania. And of course, as stated, that's not occurred at this point. So we did go through a comprehensive evaluation to really determine what the financial impact would be on our hospitals if that opportunity presented itself. And, Medicare was a player, and also Medicaid or TennCare in Tennessee and our commercial payers. It did appear, with all things being equal, that it would be advantageous to a number of our rural hospitals here. So based on that comprehensive assessment and evaluation, we have met with the governor's office and also our Bureau of TennCare, which is Medicaid here in Tennessee, just to sort of cover the same really points that Clint made earlier. And I think there is some support for that. Of course, if we decided to move forward, it would not be something that we would want to mandate for our hospitals, but be a voluntary effort. So again, we've had meetings with the key stakeholders. We've met with our member hospitals to sort of educate them on this possible opportunity. And, hopefully if CMS does come forward with something, as John stated, between now and May, at least we're better positioned to make a more informed decision. Now, what sort of transpired in Tennessee since all that work was done is our proposal to move toward a block grant type system here in Tennessee, which could potentially complicate, that particular effort. But again, at least we're positioned to make an informed decision if the opportunity presents itself.
Thanks, Bill. It's Clint.
Great. Yeah, thank you very much. Did you have a comment or question on that, Clint?
Yeah, and I just would add one other. Yeah, go ahead. I'm sorry.
No, Bill, I just wanted to thank you for your continued work there in Tennessee. You're one of the true leaders in this country, so thank you.
Absolutely. Thank you.
All right, great. Thank you very much, guys. Thank you, and please keep the questions coming into the chat feature. We structured this webinar in such a way to have plenty of time to have this discussion. So thank you for that. Again, *2 will unmute your line if you'd like to speak your question instead of typing it in. Peggy Wheeler, California is conducting very similar steps as Bill Jolly described toward a California Rural Global Budget Program. And Peggy, Bill, when I was speaking to him on the phone last month about that, that was one of the things that he talked about in that the collaborative efforts between the Tennessee efforts as well as the California one. So I think this is starting to be a trend that we'll see more and more of. So I've got a couple kind of thoughts and questions here. So John or Clint, or Terry for that matter, anyone, in general, how are the rural hospitals who are participating in ACOs, how are they doing with it? It's been, you know, a few years now that we're starting to be able to see some outcomes as well as the risks. The early iterations of the ACOs, at least initially, were free of risk, and now that's starting to change. How is that starting to come out?
Well, I'll start and I'll let Clint finish. Clint is the expert on this. But my comment is that under the AIM-ACO demonstration, which is only 3 years, those rural hospitals that participated were highly successful in their experience. And that was for 2 reasons. One, they really didn't have any risk. What they were was provided with money that they were obligated to return to CMS if they in fact achieved shared savings. So they had there was no way that they could lose with their experience. But the experience they gained by participating in the AIM-ACO was the things that one's learning in terms of managing population health and the individuals that were necessary in order to put into key positions within the hospital, clinical providers as well as administrative, to make sure that the population's health was at the priority of their efforts. And the experience was very beneficial for them. What happened at the end of that 3-year demonstration was that when confronted with having to take upside risk in the experience, they weren't big enough. And as Lynn Barr from Caravan says, size matters. Clint?
Well, a couple things. First of all, John, you're just exactly right about the AIM program. I remember a CMS brief that suggested that the program probably saved the Medicare program itself $200 million. So this is wildly successful both from the hospital perspective and from the Medicare perspective. But I want to focus on something else, and John, you touched on it when you talked about population health, and Terry, you touched on it when you talked about the access to data. And I think that's the main reason we get into this, is we get experience with taking care of our community and our population. That is a new skill set for a hospital, and for a doctor for that matter, to be able to learn how to care for populations, not just individual patients. So getting that experience is critically important. Number two, having the data to make wise decisions is critically important as well too. And as the examples that Terry gave, it's just really critical as we kind of move forward. The last thing that I want to comment about is every time we talk about success in ACOs or maybe these other models, we tend to immediately go to cost. And I think that's a mistake. We are in the business of healthcare to improve the health of people. Now, we can and should argue about how do we assess how well we are improving the health of people. But let me just say this. For better or for worse, we've chosen, I think it's 33 outpatient measures to assess the quality of care that ACOs are providing. And almost universally, that quality of care is improving among the ACO program. Isn't that important in itself? And I'm not sure why that's not spoken about more. In fact, our group did a study of this and found that on average, the overall quality scores in rural ACOs was improving at a better rate than in the urban ACOs. So we have a story to tell there, and I would like it if every time we talk about cost savings and value-based programs, we also talk about care improvement as well.
And Clint, the other aspect of that is 11 of those quality measures were prevention and wellness
yes.
measures, which is just so important in that regard. And as we evolve here, I mean, what it's really to come down to is can we basically document our value? Can we show that we're judicious in our choices of treatments, high quality, and again, the quality scores in these were in the 90% for our rural, rural ACOs, absolutely. And so those pieces come out. Whether or not we made money on an ACO, if we improved our quality and we started looking at different dimensions of healthcare, including wellness and prevention, that seems to me as a pretty outstanding outcome. One thing I want to mention though is that what I think ACOs are not the answer for all rural hospitals or any of these value models. I think if you are in really deep financial difficulties, jumping in an ACO isn't necessarily the best move because it's going to take a lot of energy in any of these models. And if you're in desperate financial straits, my experience has been that's really what you're going to focus on until you can get your head above water.
Yeah, I think that's a good point, Terry. And we've got a few things I want to make sure I'm referring back to our chat box. Did Bill, did you say you had a global budget template that was used to create the assessment for each hospital? If you do, would that be something that you'd be able to share with the group and we could distribute via TASC? And if Bill's no longer with us, I'm happy to send that question on to him.
Can you hear me now?
Yes, sir.
Okay. Sorry for the complication around muting and unmuting the line. So we actually did develop a white paper and an assessment of the hospitals here in Tennessee. And I'll be glad to share that white paper and analysis with everyone. So there's nothing confidential about it. So Caleb, I'll get that to you and you can share with the group.
That'd be great. Thank you very much. And we'll get that sent out with the notice that to everyone that the webinar recording is live. And I will remind everyone on the bottom left is the file share where the presentations as well as the federal office, the project officer map can be found. So we'll make sure to get that sent out. Thank you, Bill. Jack has a comment relative to size matters comment. It would be interesting to know what the average NPR is of a critical access hospital participating in an ACO and enjoying the shared savings.
Well, this is Clint. I'm not sure I know the answer to that question, though it should be known. I would say, however, that the number of ACOs actually resulting in shared savings is still pretty low. A couple of years ago it was 25%. I think it's up now to the upper 30s. But and I can't tell you the breakdown in that of rural versus urban. But the point is this isn't a model to enter into with the thought that you're going to make a killing on money. I just don't think that's going to happen very often. Instead, concentrating, as we were discussing before, on data access, understanding population health probably is the more important motivator to be participating in ACO. And secondly, I think no one really thought or thinks that ACOs are the end-all program. This is always thought to be an iterative process until we move to something else. Now, what that something else is, I'm not sure yet, but the rest of the world tends to use hospital global budgets. So maybe that's where it's moving. I don't know. We're still kind of on that journey trying to figure it out.
I think that's a great point, Clinton. That was one of the questions I wanted to pose to the group is, the sustainability of these models. And I think that the main point is we're on the right track. We're now looking at quality and outcomes and focusing on the health of our community as opposed to just episodic care. And there are a lot of things, to Clint, your point earlier about the providers and not getting lost in that, because right now providers are paid on that episodic care as well, and we need to address that point as well. So we've got around 7 minutes left in our time here today. I want to make sure we focus some time on the chat box. And John mentioned that Dr. McKinney's point about data is very important. Access to and analyzing data on local population is hugely important to their experience, to those participating. And I think we can speak about that as well. But I want to ask one question before we get too far away, and that is, what in general or specifically can Flex programs and Flex coordinators do in relation to this? For hospitals, speaking to legislatures, what are some of our takeaways? What do I do with this now that I'm a little more informed about these new models of care? What do I do?
I would say, this is John, from my perspective, it's educate and inform. A lot of these things are still incubators and are still being formulated, but where we're educating and informing is really at the provider level and the community level as to how it is they provide care now and does it work. And there are many robust critical access hospitals who are functioning extremely well under a fee-for-service system. Mm-hmm. And mm-hmm. they're not inclined to change the way that we've discussed in terms of new payment and delivery models. But for those who may be less robust and experiencing more uncertainty, the place to start is, what is your strategy? What do you know about your community's needs? And how are you tooled to meet those needs where your residents want them? There are consumer models that work and consumer services that work at the community level that are very appropriate. And it takes a lot of innovation and a lot of visionary thinking, but that doesn't happen until we're educated and informed as to who we are and how we're functioning now and what are the opportunities that are in front of us.
John, this is Clint. I think that is so true, and I have been surprised by the number of hospitals where I've worked that did not have an active strategic plan, let alone one that's thoughtfully engaging the community and thoughtfully engaging national partners in alternatives to payments. What I think the Flex monitoring team can encourage is to ensure that all of their participating hospitals do indeed have a strategic plan, And if they're not versed in how to do that, they're provided the resources to learn how to do a strategic plan that actively engages the community. Secondly, that they do accurate and well thought out financial performance. As I commented earlier, rural hospitals are already at risk. Now there are exceptions, as John pointed out. Some hospitals are doing quite well, thank you, and rural hospitals. And whether that is a function of great leadership or whether it's a function of an economic base in their community that's better than others, who knows. But the point is, many of us are at risk. So doing nothing, when you choose to do nothing, you've made a choice. So I would choose that we do thoughtful engagement in value-based opportunities, not more than simply staring at your navel, but not quite burning through your reserves. And if the Flex teams, the Flex leadership teams, can help hospitals make those kind of decisions and offer them opportunities to participate at a relatively low risk in some of these value-based models, I think that would be a great benefit.
I think that's
and then I think, yeah, and then following up on that, we are transitioning into models that are going to require population health management. So it's one of the, one of the components in our Flex program, and in essence, we're moving into a quasi-public health space. I mean, in many cases, our Flex programs, aren't well grounded in hospitals, but virtually all of them are pretty darn well grounded in public health. So as we start looking at prevention and wellness and community work, et cetera, I think our Flex programs can help facilitate the connections between our hospitals and clinics and our communities in general. Bring the public health providers and the pharmacists and the mental health providers and the long-term care providers together with the hospital. I mean, anything that could be done to facilitate that conversation is not only going to be great for the hospitals and clinics, because that is this next big step, but secondly, it's going to be great for the rural communities as well.
Mm-hmm. So
yeah,
true.
I agree. I think there is a shift and a change happening, that care is being reimbursed or paid for more and more by outcome and more on cost. And to Clint's point, you can choose to continue getting paid or reimbursed for your care how you have been, but make sure to make sure that's the best option for you and your community, not just your bottom line, but there are a lot of things to consider, and make sure that's a conscious effort instead of just refusing to look around and then you're so far down the road. We have 1 minute left. I will ask Andy to put up the exit polling question. As Mary also asked Peggy, if you're still on the line, if you created your own tool during your assessment process, and I assume if you did, that we would like to